In this video, I will do a full breakdown of the infraspinatus muscle, a main cause of rotator cuff pain and shoulder bursitis. Expect to learn the function of the muscle, clinical presentations when dysfunction is present in the muscle, detailed palpation instruction, and functional-based treatment demonstrations. For those of you that don't know me, my name is Dr. Matt Maggio. I am a soft tissue injury treatment expert, specifically for neck, shoulder, sciatica, and hip pain. My focus is on finding and fixing adhesion, also known as scar tissue, and then reducing inflammation from chronic injuries without the use of drugs, injections, or surgeries, which does lead to a significant increase in overall functioning, flexibility, and long-lasting pain relief. I am also the creator of the soft tissue treatment revolution, where we teach overworked massage therapists a new treatment system that will allow you to double your income, all while working 50% less, so you can stay healthy, avoid that dreaded burnout, and help a hell of a lot more people get out of pain for good. All right, so infraspinatus muscle breakdown, function, clinical presentations, palpation, and proper treatment. Let's get right into it. So, what is the function of the infraspinatus? Most classically, it's known as an external rotator of the glenohumeral joint. If you don't know what the glenohumeral joint is, it is the shoulder, basically external rotation. That's what most people think that it does. It's one of the muscles of the rotator cuff. Another job that gets overlooked a lot is its role in stabilizing of the glenohumeral joint, also known as the shoulder. So, anytime someone's pressing or reaching or using the shoulder, the infraspinatus provides a lot of stabilization of the back part of the shoulder as well. It's very involved in the stabilization as well. Most people typically only focus on the movement of it, which is the external rotation, but the stabilization is really key to shoulder function, health, good and proper biomechanics. So some common injuries associated with infraspinatus dysfunction. One's just going to be rotator cuff injuries. I always laugh when I have some clients that say rotor cup. It's not rotor cup, rotator cuff. It's one of the four muscles of the rotator cuff group. Want a little review? Infra, supraspinatus, teres minor, and subscap. It basically is the infraspinatus is the most powerful muscle of the posterior part of the rotator cuff muscle group, and a lot of times it gets overworked, and then people present with some type of rotator cuff injury. Another one is going to be winging scapula. I see this a lot from people where they're like, "Oh, the client presented with winging scapula." A lot of times, the winging scapula is actually a biomechanical leverage that the serratus does, specifically serratus anterior, when the rotator cuff, specifically in the infraspinatus, cannot provide enough movement and stability to the shoulder, like I talked about. That scapula wants to wing out a little bit to help kind of give it more of a biomechanical advantage. So a lot of times the winging scapula presentation isn't actually the cause of the problem. It's actually an effect. It's a compensation for underlying problems in the rotator cuff, specifically in the infraspinatus. Next one is the shoulder bursitis. I don't like the diagnosis of bursitis. It doesn't really tell me anything. It just basically means there's inflamed bursa of the shoulder, but doesn't tell us why it's inflamed. It's once again one of the effects, but not the cause. Next one is going to be shoulder impingement. I don't like shoulder impingement either, because I always want to have a tissue specific diagnosis about what's going on, because if we don't know where the problem is, we can't fix it. But essentially goes back to exactly what I said earlier about that role of the infraspinatus in shoulder stabilization. It's so important. And when it can't function how it's supposed to, especially when it develops a lot of adhesion from overuse injuries, the muscle becomes weaker and less flexible. It cannot provide stability to the joint, the cartilage, which in turn puts some damage in there also on the tendon and causes some of those shoulder impingement presentations. But a lot of times there's an underlying problem with the infraspinatus that actually started it. Those other things are the effect of it. And then lastly, like I said, cartilage and labrum tears. The cartilage of the shoulder really wants to cushion in between the humerus and the scapula. And when the shoulder can't have proper stability because there's dysfunction in the infraspinatus, it causes the shoulder have to move more, put more wear and tear in there, in turn puts problems on the labrum, the cartilage, and the joint itself. So a lot of people end up presenting with cartilage tears, shoulder impingement, maybe rotator cuff dysfunction, and that's what they think is the actual problem, but that's the effect of what's going on. The real cause is the underlying problem in the infraspinatus muscle. It's probably the one that's going to get the most damage and most overuse in the body, especially with bad mechanics, biomechanics, sitting too much, not doing the right type of movements. It's going to put a lot of other things cascading in a shoulder injury presentation. So First thing I want to show this week is how to actually find the infraspinatus. There's a lot of landmarks that we use here, and I like this photo that I have here. It really shows the definition of where that infraspinatus is. And I'm going to link up a video first, me showing some of the landmarks so you know that you're going to be on it every single time, because I always say if you can't find it, you can't fix it. So I'm going to link up a detailed palpation video right now. So the first thing we're going to do is just get in there and palpate the infraspinatus. So one trick that I like to do is I like to have a little bit of tension here. So I'll have the patient just kind of reach around and open up their arm. That gives a little tension on there. And then what I do is I just find my landmark. So here, across here is the spine of the scapula. So I know infraspinatus lives anywhere in through here. So what I do is I just get in there and I'll just sink in and palpate. And what I'm trying to feel for is areas of decreased compressibility. That lets me know that's area of scar tissue. And there's a pretty good one right there. I'll check that whole muscle. So just a couple take homes from the palpation video. Use the landmarks, find that superior angle, find that spine of the scapula, find that medial border, find the inferior angle, find everything else in there in the lateral border. And then you know for sure that you're on it. And the thing about the infraspinatus is it's not very deep, so you don't want to be too compressive with it. And it sits right on the back part of there, and you're going to be able to find it if you slow down and use the landmarks. Don't be in such a hurry to jump in and just want to do the treatment right away. Do the palpation first, slow down, find it so you know for sure that you're on it, then you can actually fix it. So how to effectively treat it? The biggest thing with any type of treatment, and in my treatment method called the 𝐓𝐡𝐞 method, where basically we go in and break down adhesion, break down scar tissue, you got to go slow, you got to go precise, and you got to go focused. And you want to use the landmarks, like I said, the superior angle, the spine of the scapula, the medial border, and the lateral border, to really make sure that you're on it and you're on the area. Because basically we want to do a detailed palpation. And when there's adhesion present in the muscle, it actually has decreased compressibility. Like it doesn't feel like it has as much give to it. And that's where that adhesion is, and that's where you want to treat. So what I want to demonstrate and show this week in the video is a demonstration of me treating adhesion directly in the infraspinatus. So I'm going to link that video up right now. So we're going to do the treatment on infraspinatus, and this one is a very important treatment. A lot of times people are too compressive and don't account for the angle of the scapula. So the way the shoulder sits in just like this is essentially it's kind of curved a little bit, and that infra goes right through here. And what happens is people become too compressive and they don't get the proper depth and tension, and then it just gets stuck and it doesn't slide. So for this treatment, I like to have the client sit in a chair. Anytime we get the client to sit in the chair, it's better for you and also for the client as well. The key here is the client is going to help you with the motion. And what you're going to do is start their arm just like this, and they're going to bring it straight across, nice and easy. When it gets close here, you're going to have them grab on the other arm and pull just slightly. Now, they're not trying to yank it all the way over. It's a nice, easy, gradual motion. When it gets close here, you want to pull it in just enough for that elbow to clear the chin. So you want to make sure the client really understands the motion, because if the motion isn't good, you're not going to deliver an effective treatment. So the key here is the actual vectors and the way that you go in. So a lot of people go straight in just like that, and it doesn't allow you to get an effective treatment. So essentially what we're going to be doing is this arm is going to correlate and line up with that, kind of just where it was in like that, where I'm going to come in just like that. So a lot of people are here. We want to actually get our depth in like that and our tension across to account for that curve of the shoulder blade, because it's about a 40% curve. Now the client already knows the motion, so essentially what you're going to do is you're going to get set up just like this. And you don't need to be too compressive in here. All that's between you is some skin, some subcutaneous fat, and then the actual infraspinatus. And it doesn't need a lot of pressure. Now, the first thing you're going to do is line that up just like that. Now my thumb is nice and lined up, and I want to make sure my arm goes down into that vector. Then I'm going to go at a 45-degree angle just like this, and I'm going to back that thumb up. And essentially, I'm going to sink and get my depth by just pushing very slightly with this opposite pec. That's going to get my depth. And then my tension is going to be a body lean across just like that. So what you'll see is essentially The pec gets that, and then my tension is going to be leaning away. And what I'm going to be doing is dropping my body towards the opposite way there. And you want to be at that 45-degree angle. So the client already went through the motion, they know what it is, and you're going to set up. So you're going to go in just like this, going to sink in a little pec push, and then a body lean just like that, and then the client's going to move it across. We're going to force that scar tissue to come to us. This is internal slide. Now I want to show one without me backing it up. So we would have got the depth just like that, and then our tension just like that, and I'm staying here and I'm letting it come to me just like that. Nice. So as we said here, the vector is very important here, and the setup is as well. See how I'm pointing away? It's almost like I'm going there. A lot of people come in too much here and they're not going to get the correct motion. So the key is in that setup. So I'm here, I'm nice and crouched down in a good position, very strong in my legs. Then I get my depth with this push, and then my tension is leaning with my body. Go ahead, and I set it and let it come to me. And I force that to roll over. Now this area is very common for a lot of scar tissue. The problem is everyone is way too compressive, and if you're too compressive, you're not going to get the right amount of depth and the right amount of tension, and you're not going to break that down. But if you can set up properly and take the time to set up and make sure your mechanics are right, your elbow is lined up, it's going to make for a much more effective treatment. It's actually going to fix shoulder problems. So just a couple take-homes from the treatment demonstration. One is going to really be proper depth. In order to break down adhesion, you need proper depth, and then you need proper tension, and then have the client go through a full range of motion. A lot of myofascial release treatments out there, they actually are way too compressive, and they don't allow for that tissue to slide. You need the tissue to slide under your thumb, under your fingers to actually break it down. But the thing about the infraspinatus is it sits right on the back part of that shoulder blade. It's actually not very deep. So if you're too compressive with it, you're just going to jam it into the bone. It's going to hurt like hell. And the clients think you're going to be doing something, but you're not actually doing anything. You're just jamming it into the bone. You really want to just do about 8 to 10 ounces of pressure. Then you want to generate that tension. You want to feel that tissue slide under your hands. Don't do pin and stretch. I hate that. I hate when I see that, where you're just jamming down and it's pulling and you think you're doing something. Another thing you can catch here, which is actually very important in rotator cuff dysfunction, especially in the infraspinatus, is a entrapment of the suprascapular nerve. It actually comes right out underneath on the spine of the scapula in the suprascapular notch. And a lot of times that's where the adhesion occurs because it gets stuck to the nerve. And we go in there and we can actually break it down similar to the treatment that we were doing just for the muscle. And we'll catch that nerve entrapment, because when there's a nerve entrapment in there, it really red lights all the motion in there, causes a lot of compensations in the shoulder and a lot of dysfunction. And anytime you find a palpable adhesion, you really only want to treat it for about 5 to 7 passes. You don't want to do any more than that. I always say treatment is like a medication. You want to get it just right. You want to get the dosage right, because if you overtreat it, you overdo it, you're actually not going to be able to fix it. You're going to cause more problems in the long run. So that's all I got for you in this video. If you're struggling to figure out exactly what's going on with your client's injury presentation, you feel like you're stuck guessing and always on the path to learn some new type of advanced technique, only to be stuck in the same loop of winging it and trying more stuff, then go download our free training modules that help change the way you critically think about figuring out the issue and treating in a new way that gets long-lasting results, and get on the path to being a true problem solver. Links for all that can be found in the description box below. I appreciate you watching the video.